Hello everyone, today we will cover approach to childhood anemia. Starting off with its definition. So, anemia is nothing but decrease in its hemoglobin content, that is decrease in the RBC level. So, hemoglobin when it is less than 2 standard deviation below the mean, when it is less than 2 standard deviation below the mean for the child of same age, gender and altitude of her or his residence. Okay, so this is the definition of the anemia when the HB is less than 2 standard deviation. Okay, we'll see its clinical signs and symptoms. This is just a shorter topic, okay, just to write it in your 5-mark questions like that. Okay, its clinical symptoms and signs. So first will be increased pallor, that is pallor is the most common sign. This is the most common sign in child with anemia. Second will be tiredness. Third, weakness. Fourth, easy fatigability. Fifth will be reduced concentration. In the children in an adolescent age group, they will be having an increased hair loss also. A child will have breathlessness when the anemia is severe. I'll tell you the cutoff for this according to WHO. So facial puffiness, these all will be in the severe anemia cases. That is breathlessness, facial puffiness with pedal edema. Okay. These are the clinical signs and symptoms in children with the anemia. Next we'll see the criteria for HB criteria according to WHO. There is a recommended cutoff, HB cutoff values. Okay, so they have classified anemia into no anemia, mild anemia, moderate anemia and severe anemia. I will tell you the values only for the pediatric age group now. So when the child between 6 to 59 months of age, that is 6 months to 5 years, you call the child has no anemia when the HB is more than 11, and you call this child is having a severe anemia when the HB is less than 7. Okay, this is 11 and this is 7. Mild and moderate here is mild will be between 10 to 10.9. Moderate will be 7 to 9.9. Okay, this is you call it as moderate anemia. When the child between 5 to 11 years of age group, no anemia is more than 11.5. 11 years, so it is more than 11.5. 5 years, so it is more than 11.5. Severe will be less than 8. In children between 12 to 14 years of age, the child is 12 year, you call it as no anemia when the child has HB content of more than 12. Severe anemia is same as 5 to 11 years, that is less than 8. So what will be the mild and moderate anemia in these both age groups? Mild anemia will be between 11 to 11.4. Since it is 11.5 is no anemia, so 11.4 will be mild anemia. Aduvey vandu in 12 to 14 years age group, it is 11 to 11.9. That is mild. Moderate anemia is between 8 to 10.9. Here is also 8 to 10.9. Okay, this both will be same in these both categories, that is 5 to 11 years and 12 to 14 years. So this one you have to remember, at least you have to remember this no anemia category and severe anemia category. Okay, for this 6 to 59 months, 5 to 11 years and 12 to 14 years. Okay, this is about the WHO recommended hemoglobin cutoff values. Next we will see the classification, that is etiological classification of the anemia. So first is etiological classification. So you classify this etiological classification is classified in 3 groups. First is decreased effective production. When the production is reduced or when the destruction is increased, or there is an increase in the destruction of your RBCs. Third category will be blood loss. Okay, this is the main subheading for its etiological classification. Under decreased effective production, we have 3 points. One is there can be due to deficiency. So deficiency of what? Deficiency of iron, folate, or vitamin B12, or vitamin C. Okay, so then there is a deficiency of iron, folate, or vitamin B12 or vitamin C. How the deficiency can occur? This deficiency can occur in 3 formats. When there is a reduced intake, or when there is an increase in the demand. An increase in demand is during the pregnancy state, or when the child is growing, that is in the adolescent age group. Okay, and when there is a reduced absorption. Okay, so these are the reasons that can lead to deficiency of these things. Second can be due to bone marrow failure. When it is due to bone marrow failure. So I have written only the one example for each of the category. Okay, so in bone marrow failure, it can be a congenital red cell aplasia. Example, Diamond-Blackfan syndrome. Second can be acquired red cell aplasia. Example, transient erythroblastopenia of childhood, or when there is a failure of all the cell lines. So failure of all cell lines will lead to aplastic anemia. Okay, so second reason for decreased effective production is bone marrow failure. So here we have congenital red cell aplasia, acquired red cell aplasia, and when there is a failure of all the cell lines. The third reason can be due to bone marrow infiltrative disease. So bone marrow infiltrative disease, it can be either leukemia or lysosomal storage disorders. It can be a leukemia or lysosomal storage disorder or tumor, metastatic tumors. Okay, so these are the 3 main reasons for decrease in the effective production of the RBCs. Okay, next we'll move on to the increased destruction. In increased destruction, it is mainly hemolytic anemia. Okay, in hemolytic anemia, it can be classified as either intracorpuscular cause or extracorpuscular cause. So that is, intracorpuscular is within the RBC, extracorpuscular is outside the RBC, that is leading on to the destruction. So it can be either intracorpuscular. In intracorpuscular cause, first can be either due to the defect in the membrane. So membrane defect. So membrane defect of RBCs can lead to hereditary spherocytosis, hereditary elliptocytosis, or hereditary stomatocytosis. Here, this is tomato. Okay. So hereditary spherocytosis is most common among these. Next, it can be due to enzyme defect. Okay. So enzyme defect can be either G6PD deficiency, or pyruvate kinase deficiency. Okay. Third thing can be hemoglobin defect. So hemoglobin defect is defect in the chains of the hemoglobin. That is, can be thalassemia. Either it can be a qualitative defect or a quantitative defect. Thalassemia, sickle cell anemia, HBC disease. Okay, these are the examples of intracorpuscular causes. Next, we'll see the causes of extracorpuscular causes. So extracorpuscular causes are, it can be either immune mediated. So immune mediated is like our autoimmune hemolytic anemia, or it can be acquired hemolytic anemia. Next, it can be mechanical cause. So mechanical causes are when the child have a prosthetic heart valve, the child has prosthetic valve or HUS. Mechanical is, for example, I'll tell you, when the blood vessel is defect, or when there is an injury in the blood vessel that is leading on to a thrombosis formation. So while the RBC is penetrating through such type of blood vessel, the RBC will get broken up. So that can lead to this anemia. So prosthetic, when the child is having a prosthetic valve, HUS, or disseminated intravascular coagulation, that is DAC. Or when the child is having infections that is mainly related to this blood vessels and also to the RBCs, like malaria. Okay. Next is sequestration. Sequestration is like in hypersplenism. Okay, these are the causes of extracorpuscular causes of increased destruction of these RBCs. Okay, next we will see the blood loss. So blood loss can be either an acute blood loss or it can be a chronic blood loss. In acute blood loss, examples are GA hemorrhage. In child with this EHPVO, the child can have this GA bleeding, or when there is a trauma, or in infants, when newborn, when the child have a massive septal hematoma, or when my child is having a subgaleal bleed. Okay, in chronic conditions, it can be due to rectal polyp, when the child has a rectal polyp. Second, when the child has a hookworm infestation, or when the child has a chronic peptic ulcer. These are the reasons, or these are the etiological classification for a child to have a anemia. Okay, this is blood loss. Next we will see the lab investigations. So next is lab investigation. So what are the main investigations that is needed to find, investigate the child is having, the child have a anemia? First is, you will take CBC and the RBC indices. In RBC indices, first is you have to classify whether it is macrocytic, normocytic, or a macrocytic anemia. So you have to take a MCV, that is mean corpuscular volume. When the mean corpuscular volume is less than 75 femtoliter, it is classified as microcytic anemia. Microcytic meaning the size of the RBCs will be small. Next, when it is between 75 to 90, it is classified as normocytic. When it is more than 90 femtoliter, it is classified as macrocytic anemia. Okay. Next can be, you have to look for MCHC. MCHC is for whether to tell it is having a hypochromic, normochromic anemia or hyperchromic. Okay. In children with iron deficiency anemia, the child will be having both microcytic and it will be a microcytic hypochromic anemia. So hypochromia meaning when you see in the peripheral smear, the blood vessel, the RBCs will be very paler. That is not only the central will be paler, even in the outside, if the peripheral will be also be paler. That is called as hypochromic. While in children with hereditary spherocytosis, the normal central paler will be absent. The RBCs will be compact with full of with no pallor, with absence of pallor. Okay, that is in hereditary spherocytosis. I'll show you the images. Okay, next you have to look for retic count. Second is retic count. So what is this retic count? So retic count is this reticulocytes count. So reticulocytes are this immature RBCs are this reticulocytes. So while when you are evaluating a child with anemia, you have to do a corrected reticulocyte count. You should not just take the reticulocyte count. Okay, so it must be a corrected retic count, or it should be a reticulocyte index. So this corrected reticulocyte must be corrected for anemia, as it is the percentage, as it is a percentage of the total number of RBCs. Okay, it will be, this retic count will be spuriously elevated. So it will be spuriously elevated when the number of RBCs are reduced. Okay, so it should be corrected according to the HB or the hematocrit value. So how will you do the correction? I'll tell you the formula here. So for retic index, a formula here is retic count into patient's hematocrit value divided by 0.45. This is the formula to find the retic index. So normal retic index will be 0.5 to 2%. So when this retic count or retic index is increased, it means there is a blood loss, that is hemolysis. It can be blood loss or some the hemolysis is going on inside the body. Okay, when it is decreased, it is due to bone marrow failure. There is a reduction in the production or reduced production. Okay, so this can tell you whether it is a due to production problem or due to a destruction problem. Okay, so this is about the retic index. Next, the main thing for evaluation is, third one is peripheral smear. Okay, this peripheral smear is an essential part of evaluation in anemia. So I will show you these examples of this microcytic anemia here. This is a child with congenital spherocytosis. So this is normal RBC. This is child with congenital spherocytosis. So in a normal RBC, there will be a central pallor will be present. While in spherocytosis, this central pallor will be absent. This is due to this membrane defect. That biconcave shape. Normal RBCs will be biconcave shape. That biconcavity will be absent in children with hereditary spherocytosis. Okay, this is one. Next. This is child with iron deficiency anemia. In this, in this you can see there will be the cells will be very small. The cells will be small with increased pallor. The pallor will be increased. That is, the central pallor will be increased in this. So that is, the child with this having a microcytic and hypochromic. Okay, this is about iron deficiency anemia. Next, this is a child with hemolysis, that is microangiopathic hemolytic anemia. So in this, because this is due to mechanical reasons. That is, when the blood vessel is having any thrombosis or any damage in the blood vessels, the RBCs that is going through these blood vessels, that it will be affected. So therefore, it is leading on to this what is called as helmet cells. These are called as helmet cells. Okay, this is an example of microangiopathic hemolytic anemia. So these are the helmet cells that you see in this peripheral smear. Okay, these are the peripheral smears of some examples of the anemia. Next we'll go into its classification according to this pure lab investigations. Okay. So according to lab investigations, when the child is having anemia, that is when the HB is less than 2 standard deviation, next you have to look, when you're taking a complete blood count, you will look for the other values, that is WBC and the platelet value. So are other cell lines affected? Okay, when these are not, yes or no. Okay, this is yes or no. So for yes part I will tell you later. When these are not affected, next you look for MCV. Okay, so next you should look for MCV count. In MCV, whether it is microcytic, that is when the MCV is low. When it is microcytic, the examples can be, or it can be due to iron deficiency anemia or thalassemia, sideroblastic anemia, or it can be due to anemia of chronic disease. Anemia of chronic disease can have both microcytic anemia and normocytic anemia. Or when the MCV is normal, that is normocytic, next you have to look for this retic count. Okay, when this retic count is low or normal. Okay, when the retic count is low or normal, or this retic index, okay, I'll tell you it as retic index or retic percentage. So when it is normal or low, it can be due to infection, that is infection that is affecting the bone marrow, or it can be due to lead poisoning. In lead poison, it mainly affects the bone marrow, so it can be due to lead poisoning. Third, when there, I have told, when there is a blood loss, there will be increase in retic count. But when there is an acute blood loss, this retic count can be low or it can be normal. Or when the child is having this anemia of chronic disease. In children with a chronic disease, the bone marrow will also get affected. Or when the child is having this is transient erythroblastopenia of childhood, that is acquired red cell aplasia. Or when this retic count is high. Okay, when the retic count is high, whether there is an evidence of hemolysis or not, you have to look. When there is an evidence of hemolysis, next what are the causes? Or when there is no evidence of hemolysis, that is why we will be seeing this blood smear, that is peripheral smear. So evidence of hemolysis can be that helmet cells, whether the helmet cells are being present or not. So these are some evidences. Or when there is a what the bilirubin count, you have to see. When the bilirubin count is increased, there will be it's an evidence of hemolysis. When there is no hemolysis, you have to look for hemorrhage. Okay, when it is present, yes, in that situation, it is a hemolytic anemia. So it is a hemolytic anemia. So in earlier etiological classification, I told the reasons for hemolytic anemia. It can be due to membrane defect. So the membrane defect can be hereditary spherocytosis, erythrocytosis, or stomatocytosis. Or it can be due to enzyme defect. Enzyme defect can be G6PD deficiency or pyruvate kinase deficiency. Or it can be due to hemoglobin defect. Hemoglobin defect can be thalassemia or sickle cell anemia. Okay. These are intracorpuscular. Extracorpuscular can be autoimmune hemolytic anemia or can be microangiopathic hemolytic anemia. Okay. So these are the causes of hemolytic anemia. Or next, when this MCV is macrocytic, that is when this MCV is high, that is macrocytic, what are the causes? Okay, so here the causes can be, when the MCV is high or macrocytic, the causes can be vitamin B12 deficiency or folate deficiency. Second can be due to drugs such as anti-epileptic drugs, or it can be due to when the child is taking methotrexate, or when the child is having congenital red cell aplasia, that is example Diamond-Blackfan syndrome. When there is hypothyroidism, there will be this macrocytic will be present. Okay, so these are the examples according to this MCV. Next we will see for this reason, that is when the other cell line is also being affected. Okay, so child with a HB of less than 2 standard deviation, you classify it as anemia whether other cell lines you are going to see when the other cell lines are affected or not. So when the other cell lines are affected, that is yes, what will be the reasons? So when the child is having a pancytopenia, okay, so pancytopenia here is both WBC, among the 3 cell lines, either 2 cell lines will be affected, either 2 cell lines are being affected. It can also be classified as pancytopenia. So it can be due to leukemia or myelosuppressive drugs. Third reason, it can be aplastic anemia. Fourth, infection. Fifth, B12 deficiency. Sixth can be due to hypersplenism. Okay, or when the child is having an anemia with low platelet count. So only platelet and HB is low. So these can be due to hemolytic uremic syndrome, TTP, or it can be due to DIC, or it can be due to Evans syndrome. Okay, next, when the child has anemia with high platelet count. So anemia with high platelet count, the reasons can be iron deficiency anemia. In iron deficiency anemia, it can be a compensatory increase in the platelet count, or can be due to infection. Third, post-splenectomy anemia. Okay, these are the reasons in a child with anemia with increased platelet count, or when the child is having anemia with high WBC count. With high WBC count, so it can be due to only 2 reasons, that is infection, second will be leukemia. Okay, so here we will be looking under differentiate between leukemia or leukemioid like reactions will read among that, no? It will be like that. Okay, so this is about a shorter form of child with anemia. Okay, this is how you are going to classify. Thank you. Have a nice day. Let's all learn pediatric together. Thank you.